Yo, it's time for Psychiatric Pharmacology. It's time for the fun stuff. Now, I will admit in advance, Psych Pharm is some of the hardest stuff to remember in the book, especially since it's difficult to conceptualize why some drugs are used for various indications. Unfortunately, though, this is some of the most heavily tested pharmacology on the boards, and it's definitely worth your while to invest some time in learning it well. Along the way, I'll give you some acronyms and other mnemonics we use to keep it all straight. This first fact, treatment for selected psychiatric conditions, is designed for you to have a quick hit list to refer to. And we'll use it as a platform to discuss some of the commonly used medications for common psychiatric illnesses that we discussed during the pathology section of this chapter. While we won't read through all of these medications together, let's focus our attention on a couple of the more important ones to remember. When thinking about medications for bipolar disorder, the main medications fall into two major categories: the so-called mood stabilizers and the atypical antipsychotics. Now, the mood stabilizers include lithium, valproate, and carbamazepine, all of which work differently, and it's not necessarily clear how all of them stabilize patients with bipolar disorder. Atypical antipsychotics, while effective for patients with schizophrenia, as their name may imply, has also become a mainstay of therapy in patients with bipolar disorder. Now, it's important to remember specific drugs if they're listed for patients with specific illnesses. For example, while clomipramine falls into the category of tricyclic antidepressants, it's prescribed for patients with OCD. So it should be remembered solely as a treatment option for OCD in this case, and not as a class of drugs. Similarly, mirtazapine is used for patients with depression with insomnia, as mirtazapine is well known for its sedating effects. Another key to remember about this list is that SSRIs, selective serotonin reuptake inhibitors, are used for a lot of illnesses. Mainly treatment for illnesses associated with unhappiness or anxiety, and that's generally how I like to conceptualize what SSRIs treat. And these diseases include anxiety, bulimia, depression, OCD, panic disorder, and PTSD. And this makes sense since SSRIs are going to increase serotonin availability, which is a mood-enhancing neurotransmitter. So, know all the diseases that are treated with SSRIs. And this makes SSRIs a very safe choice if a multiple choice question offers them as an option and you don't know the answer. It's similarly important to remember which diseases you should not give SSRIs for. And two important ones are schizophrenia and bipolar disorder. And that makes sense because the effects of SSRIs may exacerbate symptoms of mania or psychosis and would be unproductive, to say the least, in treating the root of the patient's disease. The first set of drugs we'll discuss is the CNS stimulants. These include methylphenidate, dextroamphetamine, methamphetamine, and phentermine. Their mechanism is shown here. These work by increasing the concentration of catecholamines in the synaptic cleft. And the catecholamines are norepinephrine and dopamine. They do this by inhibiting catecholamine reuptake. And they also reverse the flow of catecholamines through the channel so that catecholamines flow out into the synaptic cleft, flow out, rather than back into the synaptic bulb. You can use this class of drugs to treat diseases such as ADHD, narcolepsy, as well as to control appetite. And it makes sense that CNS stimulants would it be effective for patients with narcolepsy, though intuitively it's not clear why it helps patients with ADHD and appetite control. Some theories around its use for ADHD say that it causes the brain centers that encode attention to be stimulated, and this suppresses distracting thoughts. This next class of drugs is the typical antipsychotics, and it's very important to study these because they're very high yield. Now, the first thing to remember is that all of these drugs, with one exception, are a part of a drug class called phenothiazines. So they all end in azine, like trifloperazine, fluphenazine, thioridazine, and chlorpromazine. Just remember, though, that this doesn't include drugs like the antihypertensive hydralazine and the sulfa drugs sulfasalazine or sulfadiazine, which also end in azine, but they are not part of this class of drugs. The other classic typical antipsychotic is haloperidol, which is not a phenothiazine. Now, these drugs work by blocking dopamine or D2 receptors. And by blocking D2 receptors, this causes an increase in cyclical AMP. Because D2 receptors inhibit adenylyl cyclase. And adenylyl cyclase, remember, makes cyclic AMP out of ATP. Also keep in mind that D1 receptors activate adenylyl cyclase, so they're actually working opposite of D2 receptors. Now, it's very important to remember this mechanism of action for these drugs because they can sometimes have interactions with other dopamine-altering drugs. Do you remember what major neurological disorder involves dysregulation of dopamine in the brain? Remember from your neuro chapter, it's Parkinson's disease. And Parkinson's medications and certain antiemetics like metoclopramide may interact with these drugs. So, what are antipsychotics doing to adenylyl cyclase activity? They're increasing it by inhibiting the D2 receptors. So these drugs inhibit the D2 receptors, and therefore the D2 receptor cannot inhibit adenylyl cyclase, and therefore cyclic AMP levels increase. So these drugs are ultimately increasing cyclic AMP levels. Now, the clinical uses for these drugs include schizophrenia, psychosis, acute mania, and Tourette syndrome. Pharmacologically, these drugs are very lipid soluble and are stored in body fat, which makes them take a while to be removed from the body. So, given this fact, do you think they would move into your adipose tissues or muscle faster? It's actually a bit of a trick question. They'll actually partition into the lipid elements of muscle before adipose tissue due to the increased vascularity of muscle versus fat. But more of the drug will ultimately end up in adipose tissue because of the lipid solubility. Now, the key to learning these drugs for the exam is understanding their common and life-threatening side effects. The more common side effects from these drugs are mainly the extrapyramidal side effects. And these are called extrapyramidal because they consist of the neural pathways external to the voluntary motor pyramidal pathways that run in the medullary pyramids. So external to the voluntary pathways. So the extrapyramidal system consists of things like the basal ganglia, cerebellum, and nigrostriatal pathways, and that is why extrapyramidal side effects affect the patient's movements. These effects often vary based on the duration of use by the patient. Within the immediate first 4 hours of use, patients may experience acute dystonia, including muscle spasms, stiffness or even oculogyric crises, which are spasms of the extraocular muscles. At 4 days, patients may notice akinesia with Parkinsonian symptoms. Then at 4 weeks, patients may notice akathisia, which is in Greek almost literally translates to an inability to sit still. And then finally, the late effects manifest as tardive dyskinesia, which is characterized by stereotypical oral and facial movements. And once these begin, it's often difficult to reverse, even with cessation of the medication. Another set of side effects that are known to occur from the use of antipsychotics are endocrine side effects. And this stems from the fact that increased levels of dopamine suppress levels of the hormone prolactin. And therefore, inhibiting dopamine receptors will cause what? It's going to lead to an increase in prolactin levels, causing hyperprolactinemia, and this will cause galactorrhea, as well as menstrual irregularities such as amenorrhea. Another set of side effects occur as a result of the cross-reactivity of antipsychotics. Even though these are designed to antagonize dopamine receptors, antipsychotic medications will have effects on other receptors as well. They may block muscarinic receptors, which would cause what kind of symptoms? It would cause atropine-like symptoms like dry mouth and constipation. They can block alpha receptors, which would lead to hypotension, and they can also cause histamine receptor blockade, which will lead to sedation. In patients with acute psychosis or mania, this histamine blocking effect and the resulting sedation is actually a part of the desired effect when this medication is administered. The final side effect is one of the more worrisome and potentially life-threatening ones, although it's rare, and it's neuroleptic malignant syndrome, NMS. And the symptoms of NMS are individually somewhat nonspecific, but as a constellation of symptoms, there are not many diseases that look this way. And the memory aid is fever. So fever stands for, first one is fever, encephalopathy, vitals unstable, elevated enzymes, and rigidity of muscles. And the muscle rigidity is often one of the giveaway clues if you get a question on this disorder. The enzymes are elevated, and this will often include increases in myoglobin, which may also appear in the urine. Also, the fever tends to be very elevated to ranges that may not be compatible with life, often 103 to 107. Treatment for this is prompt administration of dantrolene, which is a muscle relaxant, and also patients are given dopamine agonists to help reverse the effects of the drugs. So in terms of question stems, look for a patient that runs an extremely high fever after taking medication for schizophrenia. Before we move on, there is one final set of side effects that are worth remembering for two low-potency typical antipsychotics, chlorpromazine and thioridazine. And both of these can cause deposits in the eye. The thing, though, to remember is that they go to different places in the eye. Chlorpromazine classically causes deposits in the cornea, and thioridazine in the retina. So remember the C in chlorpromazine for deposits in the cornea, and the T in thioridazine for deposits in the retina. It's also worth remembering that chlorpromazine and thioridazine are low-potency antipsychotics and therefore tend to have more non-neurological effects, while the others are high-potency and tend to cause more of the extrapyramidal effects, like Parkinsonism or dystonia. And you can keep the low versus high potency drugs straight in your mind with the acronym cheating thieves are low. So C cheating, T thieves are low for chlorpromazine and thioridazine. And try to fly high. Try to fly high for the high potency. Try to fly high. Alright, flash quiz. What is the reason for the long half-life of neuroleptics? Answer is they are highly lipid soluble, so there is a large volume of distribution. Thus, it takes a long time for them to be removed from the body. Now think back to your pharmacology lectures. Remember that it takes much longer for drugs to diffuse out of fat as compared to drugs that are hydrophilic and can quickly be filtered out of the plasma.